Hello everyone, I'm Dr. Alaa Mosbah, Professor of Obstetrics and the Gynecology, Faculty of Medicine, Mansoura University. Today we have an important topic which is bladder pain syndrome. What are the objectives of our topic today? To know the definition of bladder pain syndrome, the etiology, clinical assessment, baseline investigation, diagnosis of bladder pain syndrome, what investigations are used to diagnose bladder pain syndrome, how can we classify the severity of bladder pain syndrome, what is the effect of bladder pain syndrome on quality of life, treatment of bladder pain syndrome, what about bladder pain syndrome and pregnancy? Okay, this lecture, depending on the Green Top guidelines published by Royal College of Obstetrician and the Gynecologist. So let us start with the definition. According to the American Urological Association, they described bladder pain syndrome as an unpleasant sensation. This unpleasant sensation may be pain, discomfort, or pressure, perceived to be related to the urinary bladder, associated with lower urinary tract symptom of more than 6 weeks duration, in absence of infection or other identifiable causes. Okay, so it is diagnosed after exclusion of other causes. Okay, in the past they considered the duration 6 months in the previous definition, but in the updated definition we are talking about 6 weeks of these symptoms. Okay, why they updated the definition and reduced the duration to 6 weeks? To start diagnose early and to manage early. Okay, also you should know that bladder pain syndrome may be associated with negative cognitive, behavioral, sexual, or emotional consequences, as well as symptoms suggestive of sexual dysfunction according to the European Association of Urology. Okay, the term bladder pain syndrome has been recommended rather than the previous names of interstitial cystitis and the painful bladder syndrome. So don't say anymore interstitial cystitis or painful bladder syndrome, but say bladder pain syndrome. Okay, so this name replacing the name of interstitial cystitis and painful bladder syndrome. Okay, what about the etiology? Is there a definite etiology for bladder pain syndrome? Really, the etiology of bladder pain syndrome is not well understood, and the current thoughts around its pathogenesis remain multifactorial. Current research strongly suggests an underlying inflammatory process, although the precise cause for this is not well understood. Up till now, of course, researches are running. So, what about initial clinical assessment? Bladder pain syndrome is a chronic pain syndrome, and the principle of management of chronic pain should be used for the initial assessment of this condition. This is the main complaint, pain. And I said before, pain may be heaviness, unpleasant sensation, discomfort, and so on. Thorough medical history should be taken and physical examination performed, of course. So, what is the baseline investigation? Please remember bladder diary and the food diary. A bladder diary, you measure the frequency of micturition and the volume of urine should be included in the bladder diary. Okay, frequency and the volume of urine. Okay? What about food diary? May be used to identify if specific foods cause a flare-up of symptoms or not. You should use a food diary for that reason, because maybe certain foods flaring up the symptoms, increase severity of the pain, okay? And the patient should notice that. And if there is a food diary, we can recognize this problem, okay? So the baseline investigation, including a bladder diary and a food diary. Urine should be tested to rule out a urinary tract infection, as this is a prerequisite for diagnosis of bladder pain syndrome. So you should do urine analysis and urine culture. Investigation for urinary ureaplasma and chlamydia can be considered in symptomatic patients with negative urine culture and biuria. Okay, so if you have a negative urine culture and biuria, please do test for ureaplasma and chlamydia. Okay, what else as a baseline investigation? In those with suspicion of urological malignancy, urine cytology should be tested. Cystoscopy and the referral to urology should be initiated in accordance with the local protocols. Okay, so what about diagnosis of BPS or bladder pain syndrome? As I said from the start, bladder pain syndrome is a diagnosis of exclusion, and the other conditions should be excluded. Like what? Other condition in differential diagnosis? Malignancy, like bladder carcinoma, cervical, uterine, or ovarian cancer, infection of the urinary or genital tract, radiation cystitis or drug-mediated cystitis, overactive bladder, calculus of the bladder or lower ureter, bladder outlet obstruction or incomplete bladder emptying, pelvic organ prolapse, urethral diverticulum, endometriosis, pudendal nerve entrapment or pelvic floor muscle related pain, diverticular disease of the bowel, irritable bowel syndrome. All these fall in differential diagnosis. So, what investigation are used to diagnose BPS according to the guidelines of Riot College? Bladder biopsies and the hydrodistinction are not recommended for the diagnosis of BPS. Cystoscopy doesn't confirm or exclude the diagnosis of BPS, but is required to diagnose or exclude other conditions that similar symptoms like BPS. Cystoscopy without hydrodistension is expected to be normal, except for discomfort and reduced bladder capacity in the majority of patients with BPS. So, what about potassium sensitivity test, urodynamic assessment, and the urinary biomarker? All of these shouldn't be used in the diagnosis of BPS. However, urodynamic test may be considered if there is coexisting bladder pain syndrome and overactive bladder and or stress urinary incontinence and or voiding dysfunction that, that are not responsive to treatment. So as a routine, you are not going to do it, but you may do urodynamic if the symptom, the bladder pain syndrome associated with overactive bladder, stress urinary incontinence, or voiding dysfunction, so you are going to do urodynamics. Any suspected additional pelvic or abdominal pathology should be appropriately investigated. You may need a CT, spiral CT, or MRI, or whatever to diagnose pathology of another disease. How can we classify the severity of bladder pain syndrome? Clinicians should use a validated symptom score to assess baseline severity of bladder pain syndrome and assess response to treatment. So I need to know what is the degree of severity of this pain and if it is responding to treatment or not. So I need validated symptom score. So I can use visual analog scales for pain to assess severity of pain in bladder pain syndrome. Okay, what is the effect of bladder pain syndrome on quality of life? Patient with bladder pain syndrome can have a low self-esteem, sexual dysfunction, and reduced quality of life. Patient with BPS may have other coexistent conditions impacting on their quality of life. Let us go to treatment. We can classify treatment into conservative treatment, pharmacological treatment, intravesical treatment, and further treatment options. We'll start with the conservative treatment. Dietary modification can be beneficial, and the avoidance of acidic food and drinks, alcohol, and caffeine should be considered. What else in conservative treatment? Stress management. Stress management may be recommended, and regular exercise can be beneficial. Analgesia is recommended for symptom of pelvic or bladder pain. Acupuncture, is it has a rule or not? There are limited data on the benefits of acupuncture. So please remember dietary modification, stress management, and to give the patient analgesia to control pain. What about pharmacological treatment? Oral amitriptyline, which is a tricyclic antidepressant, or cimetidine, which is H2 blocker, may be considered when first-line conservative treatment have failed. So if conservative treatment failed, go to pharmacological treatment. But you should know that cimetidine is not licensed to treat BPS and should only be commenced by clinicians specialized to treat this condition. So who will prescribe cimetidine should be specialized in this condition. Okay? This is as regard the pharmacological treatment, amitriptyline and cimetidine. Let us go to the next line of treatment, intravesical treatment. So, if conservative treatment and oral treatment have been unsuccessful, other therapies may be added or substituted using an individualized approach. This will depend on the experience and expertise of the clinical team involved and onward referral to specialist center with expertise in chronic pain management and the access to professionals from other specialties. Of course, we need MDT, multidisciplinary team, to manage this condition. Okay? So what about intravesical treatment? The next option. We can use intravesical lidocaine or intravesical hyaluronic acid or intravesical injection of botulinum toxin A, which is the Botox, or intravesical dimethyl sulfoxide, or intravesical heparin, or intravesical chondroitin sulfate. Okay, all these are options. Any one of them can be used according to grade of recommendation. What about further treatment option? Further options should only be considered after referral to a pain clinic and the discussion at a multidisciplinary team meeting. Please remember that. Cystoscopic fulguration and the laser treatment and the transurethral resection of lesions can be considered if honor lesions are identified at cystoscopy. Neuromodulation means nerve stimulation, like posterior tibial or sacral neuromodulation, may be considered after conservative oral and or intravesical treatment have failed. All different other lines of treatment failed, so I can go to neuromodulation. Okay? Okay. What else for further treatment option? Oral cyclosporin A may be considered after conservative other oral intravesical and neuromodulation treatment have failed. Cystoscopy with or without hydrodistension may be considered if conservative and oral treatment have failed. What else in further treatment option if the condition is severe and all previous line of treatment failed? Major surgery may be considered as a last line treatment in refractory bladder pain syndrome. Like what? Like total cystectomy and urinary diversion in the form of supratrigonal cystectomy with bladder augmentation, bowel or supratrigonal cystectomy, and orthotopic new bladder formation will likely need intermittent self-catheterization, and the patient must be aware of the likelihood of persistent pelvic and pouch pain post-surgery. Also, there may be urinary diversion in the form of ileal loop conduit, with or without simple cystectomy, which will not require intermittent self-catheterization. So, what is the role of the MADDT, multidisciplinary team, physiotherapist, pain team, clinical psychologist? Referral to physiotherapist should be considered as BBS symptoms may be improved with physical therapy. This is very important to be known. Consider referring patient with refractory BBS for psychological support or counseling if it is impacting on their quality of life, or the patient requests a referral. Patient with refractory BBS should be referred to a multidisciplinary team in order to explore alternative treatment options. Those patients who may benefit from neuromodulation should be referred to MDT before treatment is commenced. Okay, what is the duration of follow-up? Patient should be followed up periodically in secondary care with consideration for shared care between the pain team and the urogynecology. The pain team and the urogynecology for follow-up until symptoms become controlled, and then they can be followed in primary care if required. Let us go to the last subject in this lecture, which is the bladder pain syndrome and the pregnancy. Is there is effect on pregnancy? Can the woman be pregnant? Can receive treatment? Okay. Women can be advised that the effect of pregnancy on the severity of bladder pain syndrome symptoms can be variable. So, the symptoms can be variable between women. Bladder pain syndrome treatment options considered safe in pregnancy, including oral amitriptyline and intravesical heparin. So both of them are safe. You can use them during the pregnancy, oral amitriptyline and intravesical heparin. Okay, although one course of dimethyl sulfoxide may be used period to pregnancy for symptom remission with good pregnancy outcome, dimethyl sulfoxide is known to be teratogenic in animal studies. Okay, so don't use dimethyl sulfoxide while the patient is pregnant, but you can use it before pregnancy. okay, to improve the symptoms, to cause symptom remission, okay? And it is proved that patient who received this treatment before starting pregnancy, the pregnancy outcome was good as regard delivery at term, normal birth weight, and postnatal symptom control. So this is an important point. But during pregnancy, don't use it because it is proved to be teratogenic in animal studies. This is the end of my lecture. I hope it was beneficial for you. This is my scientific site on Amazon, on YouTube, on Blogspot, and this is my books published on Amazon, textbook of obstetrics, textbook of gynecology, contraception handbook, multiple choice question book, medical disorder in pregnancy, and the gynecologic oncology book. I'll write a link for my books on Amazon in a comment, and I'll write another link for my YouTube channel where you can find many other lectures in OB guide, quizzes, case scenario discussion, and the guidelines. Thank you, everybody.